Okay, good morning, everyone. We have the pleasure to have with us Maria Macarulla Rodriguez. Maria she's here in Democritos for a short visit of 3 months. She's a PhD student in University of Valencia, and she's work on non-invasive estimation of heart electrical activity using artificial intelligence. So today she's going to present her work. Maria, the floor is yours.
Well, hello, everyone. I brought some sweets from Spain if you want to try. They're in the middle there. Okay. You can pass them through the room. Yeah. Sorry? The sweet from Spain, just from a village from Spain. Yeah, so my name is Maria Macarulla, and I'm a PhD student. I'm oriented in cardiac research. And today I will be talking about the non-invasive estimation of the heart activity using artificial intelligence. I divided my presentation in two parts. The first one, I will talk about myself and the group that I work for, and then I will move towards what I've been doing in my PhD and what I would like to do in Democritos. I am from Valladolid in Spain. It's a city in the middle north of Spain. I studied the telecommunications engineer, and then I moved to the Netherlands to do my master's degree. I spent there 2 months. 2 years. Sorry. I did signals and systems, focusing in biomedical engineering. Due to some climate reasons, I decided to go back to Spain to see the sun once again. And this time I choose Valencia. The Valencia is a coast city. It is the third biggest city in Spain. The first two are Madrid and Barcelona. And now I'm doing my PhD research there in cardiac research. It's been already 3 years. I work there in that building. My group is CORE, which stands for Cardiac Oriented Research. This is my group. We also work with a company Corify Care, and we work with hospitals in Spain like La Fe in Valencia, Gregorio Marañón in Madrid, and Clinic in Barcelona. So my supervisor is a co-founder of this company, and we focus mainly on cardiac diseases, but especially in atrial fibrillation. So I will start talking about atrial fibrillation. What is it? A brief explanation. We have here the heart with 4 chambers. The two above. The two above are the atria, and the two below are the ventricles. Is that yes? It is my photo or no? No, it is fine. It's stopped. Sorry. Okay, well, as I was saying before the blinking, this is the heart with 4 chambers. The two above are the atria, the two below are the ventricles. And the heart works with electricity. So when the electricity goes through the muscles, they contract and they impulse the blood for the body. So the electrical propagation starts in the right atria, and it goes to the both atria. And then when it's done in the atria, they go to the ventricles. And this is what happens if we have a healthy heart. But when we don't have a healthy heart, the electricity goes, or with AF, it goes chaotic. So the contraction doesn't work properly, and we suffer AF. This is what we see when we have a healthy heart. This is called signal freedom, and this is the signal from an ECG. This is one electrode. So mainly we can see equally spaced spikes. This is called the QRS complex, and this corresponds to the ventricles. They are bigger in amplitude because the ventricles are bigger, but the atria is the small mountain here, and it's smaller because the atria are smaller. And when we suffer atrial fibrillation, we don't see this small mountain. We see like a noisy signal, and this is what makes the big spikes be not equally spaced anymore. And this is because the electrical activity in the atria is going crazy. I have a video showing you how it looks in the atria. This is a simulation. The one in the left is a healthy weight, and the one in the right is the AF. The videos are not working. Okay. Cool. So we can see the electrical wave propagating in a smooth way. It starts at one point here in the right atria, and it ends here in the pulmonary veins. But when we suffer atrial fibrillation, the electrical activity looks like this. Going back to atrial fibrillation, it is the most frequent arrhythmia. Almost 60 million people suffer it, and this number is increasing rapidly. We can suffer risk stroke, heart failure, or even death. But the question is there a treatment? And the answer is yes. We have two options. The first one is drug therapy, although it is not very efficient. And we have catheter ablation. With catheter ablation, we have it's the most successful therapy, but only we get a 60% of success. So this means that 40% of the patient, the arrhythmia comes back and they have to go through another surgery. And now the question is, why is only 60%? So I present you here 3 images. This represents a piece of the heart. This volcano is a pulmonary vein. So we are showing here the veins because the veins have a tissue that is problematic. So they usually cause arrhythmia because the conduction properties of the veins are not homogeneous. So we have 3 main theories how the AF is initiated. The first one is ectopic focus. So this means that the pulse doesn't start where it should start. Instead of starting in the right atrium, it starts somewhere else. The second part, the second theory, is a rotor. So we have a vortex where the wave propagates in circles. And the third one is that we have multiple wavelengths, so they collide and they have different direction, and this is what causes the arrhythmia. And the objective for the clinician is to find where is this area, so they can isolate it electrically with ablation. And how do they do this? We have to do this normally invasively. The patient has to go into the operation room and they put the catheter inside the leg that goes to the heart. And there they measure point by point the activity of the heart. But it has some inconvenience. The first one, it is invasive. We have to sleep the patient and it is dangerous for the patient to be for a long time sleeping. And we have to measure each point of the heart. It takes a lot of time, or you can only measure a small part of the heart. And here an image. This is a catheter. So yeah, we have to put the catheter in each part of the heart. and you only measure a bit of the activity. And so the thing is, the clinician has to find where the arrhythmia is starting. And it is done in the ablation procedure. We don't have time for planning. What we can do before the procedure is go to an MRI scanner and see what scars we have or what damaged tissue we have in the heart. So with that, the clinician has an intuition where to ablate because the scars are prone to start an arrhythmia. So what my group proposes is a non-invasive method. So we can see the activity of the heart beforehand. We have time for planning. It is non-invasive. And then the doctor can go and see what to do in the ablation procedure beforehand. We do this with a vest that is like it is here with 128 electrodes. This is a real image of a patient wearing the vest. And here is how we compute the inverse problem to see the activity of the heart. Here I have a video of how it looks. It is in real time. And we measure different 128 electrodes in the torso, so we can see the complete activity of the heart in one shot. So the white is how the pulse propagates through the atria. Well, this is the first part of my presentation. If you have any questions, then I will continue with my previous work and the work that I want to do at Democritus. Regarding my work, I've been working on always with these 128 ECG signals, so the non-invasive signals, and I applied artificial intelligence because it is difficult to see a pattern or to know what activity we have in the heart with just showing the electricity in the torso. So that's why we apply artificial intelligence. And I use this for two things. The first one is estimation of the atrial tissue, and the second is for the estimation of the atrial activity. We will start with the first. As I said before, we can put the patient into an MRI scanner, and we see what scars we have in the heart. This is a video of what it looks like with an MRI scan. So we have the blue part that is healthy tissue, and the red is fibrotic tissue. This tissue doesn't conduct the electrical activity, and that is why we can start the AF there. The AF can start. The main problem is that we have to set a threshold, and there is no consensus about the threshold. Some clinicians try to put it up or down. We don't know yet where to put it exactly. And another disadvantage is that the MRI scan is not always available in all hospitals. And even though if there is an MRI scanner, you have to wait for a few months, probably, to get one MRI. Moreover, not all patients can go into the MRI scanner because they suffer claustrophobia. And although it is non-invasive, we have to inject gadolinium into the patient, and it can be dangerous for some of them. So what I did is I tried to estimate what is the location of the fibrotic or the scars in the heart in a non-invasive way. First of all, I created a database of various atria. These are instances of real patients. And then I designed random fibrosis patterns in a total of 15,000. And then I simulate the propagation in the atria. I have here two examples. The one on the left is healthy, and I showed you before. The propagation is smooth. And the red one is when we have scars in the posterior wall of the left atria. So we could see in this video that the propagation here had like a small mountains. It didn't went smooth. So we stop here in one shot. And here in the healthy pulse, we see it like a straight line. But here, when we have a scar, the propagation doesn't go exactly like this one. And we have like a small entrance here that can cause a collision and provoke AF. When I computed the torso signals from these two simulations, we can visually see differences. The blue one is the healthy, the control, and the red one is the one with fibrosis. So if we visually can see differences, the artificial intelligence can see patterns and locate exactly the area. So my objective was to locate fibrosis in 6 different parts of the atria. These are the typical parts where we find fibrosis in patients. It is the posterior wall, the veins, and the septum. I created a graph neural network with the nodes as the electrodes from the vest, and the attributes is the ECG signal. I put it into the GNN and I solved a classification problem. And I got a 48 accuracy in location. And once the model was trained, I analyzed the weights because I use an attention network. I divided in 4 levels of importance. The pink, light pink is low importance, and the 4 or dark pink is high importance. So in the front, the chest in front, we can see that the upper chest is the most important. And this is obvious because it's the closest to the heart. And actually in clinics, this is the electrodes that are normally used in the ECG, standard 12 ECG. But in the back, we can see that these are also important. And normally in clinics, they don't use these type of electrodes. So this might say that we are missing some important information just using 10 electrodes in the chest. The second part of my work was the estimation of atrial activity. So we will go back to the operation room. As I said, we need a catheter to measure each point of the heart. And then the clinician tries to see the activity of the heart and try to define where is the starting point of the arrhythmia to isolate it. And it is difficult with the signal, so what we do is compute the spectrum, the frequency spectrum. So what we see is that the highest frequency here in red, is the ones that have more chaotic activity, and it is associated with where we start the AF or maintain. So the clinician has to ablate that area. So as a summary of the process, we measure the signal, we compute the spectrum, and then we ablate the highest frequency. And what I wanted to do in my, yes, you can ask now.
Sorry, just a clarifying question. So this is the frequency of all of the signals combined?
No. So per node in the atria, per region, we have a signal, right? So we
Okay.
compute the frequency domain,
Mm.
and then we compute the maximum, the dominant frequency.
Okay.
So here are the dominant frequencies, just
Okay.
one value per node.
Okay. So you try to estimate the frequency spectrum on different places.
Yes,
Okay.
different areas of the heart.
Okay.
Mhm. So the ones with highest frequencies are the ones that are problematic. So I wanted to do this in a non-invasive way. So using the signals from the torso. And the objective was to estimate the frequency map of the atria using the ECG and a GNN. I used the database of simulation, 8600 of AF simulations between 3 and 12 Hertz. That's where the arrhythmia usually is. If we had a healthy heart, this map will look the same color because we have 1 beat per second, more or less. So it will be the same frequency all the time in all the areas of the heart. And also, this map is important not only to diagnose, but also to say how effective the procedure, the ablation was. So for example, if we ablate this heart and after the ablation, we measure again and we see this heart, this means that the procedure went well because the heart is blue, so it is low frequency. But if we ablate and after the ablation, we get this kind of map, this means that the procedure didn't work well. So my work here in Democritus, I would like to use non-invasive method and eliminate this part. So no estimation of the map, but directly work with what will be the output of a specific ablation. So we have a database of 12 different ablation per simulation, and we know the output of each ablation. By the way, this is how the ablation looks like. So the blue is the healthy tissue or the heart tissue, and the red is where we do isolation of the electrical, so the wave doesn't go through there. And I want to estimate what will happen to a patient applying the different ablations, so we can perform the best one for that patient. And after that, I would like to analyze how the GNN works to give some explainability to make the model trustworthy. To see, for example, which electrodes are used to say which ablation works best. And here I have some preliminary results. In this axis, in the x-axis, we have the real values, and in the y-axis, we have the estimated values. So the problem that I'm facing here right now is that my GNN usually says that the changes in the ablation is 0 Hertz. And yeah, it stays there. And this is mostly because the database, this is the distribution of my database. So most of the values are 0. This means that the ablation didn't do much to the heart. And this is what happens mostly in real patients, that only 60% works. So yeah, I have these results if you guys have any suggestions. And well, that's the end of my presentation.
Thank you very much, Maria. So questions?
Okay, thank you again for your work. It seems very interesting and very important. I have a question. Maybe it's a bit beyond your thesis, so it has to do with the data and has to do with the electrodes. Yeah, what's understandable about the electrodes? Okay, I would like to ask something about the data they are collected and the electrodes. So from the diagrams we saw before, I think there are two. It seems to me there are two dimensions that are important. One is the space, that is how the electric signal propagates, and the other perhaps parameter is the time. Now, I don't know if the electrodes are able to get us information about how the signal spreads or how fast it spreads, and whether this could potentially be used, let's say, in a future step in your work, which is already, of course, very interesting.
So, you are asking if with the electrode, with the information of the electrodes?
Yes, basically, how do we capture the concept of space
Yes,
and the concept of time.
like how we compute the inverse problem. You mean that? Wait one second. Sorry. Okay. Yeah, the video I showed. So one part of my group, they measure the signal in the electrodes, and then they compute the inverse problem to see how the activity in the atria is. Let's see here, this image here. So that's part of the software of the company. They compute this.
Mhm.
But what I'm working on is just the signals from here. I avoid this part. I don't compute the inverse problem.
Okay. Okay.
Mhm.
Okay. Thanks.
And the model of the atria is done with the shape model. So they are different instances of the shape model, and they fit the one that is best for the patient.
Okay. Thanks.
Any other question?
Thank you for the presentation. Very interesting and very interesting domain. Just to understand a bit how you analyze with the GNN the network of the electrodes. So you consider the network of the electrodes and the signals as a graph, right? And you
Mhm.
analyze with the GNN.
Yes.
So I see this graph has specific characteristics. For example, the degree of each node is maximum 4. If I see correctly in the image in photograph.
Yes.
So
Wait, second.
it kind of seems like a homogeneous graphs all around. So it's an interesting characteristic to take into account when analyzing this graph. I would like to understand how you use the GNNs and what's the task you're trying to solve, especially in the first place in the diagnostic problem.
Of the tissue.
Yes.
Mhm.
So you're trying actually to not to classify the whole graph, but to identify specific areas in the graph that it's the problematic areas.
No,
No?
so my graph is a torso. So this is the graph I have. And well, each node is the electrodes and the attributes are the signal. So per graph, I do a classification problem. So like per patient, this is one patient for me.
So you're trying to classify the whole graph
The
as
whole-
problematic or not.
Yes.
Okay.
From this, I say, so the tissue, the non-healthy tissue is in this part of the heart, but that is done with a classification problem. Yeah, because I divided the atria in 6 parts, and I place the damaged tissue in one of each part, and I solve the classification.
So you do not, but to fully understand, you don't try to identify specific areas in the graph where they are problematic.
No. Here with this color, it's how important the node is. It's explainability.
Hello.
Hello.
Did you try to remove these nodes and retrain the network to check if the classification score decreases or not when removing these nodes that are unimportant? Because I'm not sure about graph neural networks, but in transformers there's a big discussion if the attention weights match the notion of explainability.
I didn't remove this exactly, but I did an experiment, several experiments. The first one was I used only 10 electrodes. Then I used 20 electrodes. Then I used 30 and so on until 128. And I saw that from 100 electrodes, more or less, the performance was pretty the same.
No matter what the electrodes were,
I
you choose them
removed them.
randomly.
Yeah, I removed them randomly. Yeah, I didn't try to remove this exactly. And well, another thing that I saw that, for example, when I had a big tissue damage, like a big part of the atria, I don't need specific electrons. Like the graph tries to distribute the importance. So in those cases, if I remove a lot of electrodes, it was okay because the importance was in another electrodes. But when we have a small area in the heart that is damaged, the GNN focuses on small parts of the graph. So in those experiments, when I remove some electrodes, it worked worse. I don't know if it makes sense for you.
I'd like to understand a bit more exactly what you're trying to predict in the other problem.
And the last one?
Yes.
Okay. Yeah.
So you showed that the result of ablation is around 0 hertz, right?
Yes.
So
mhm.
this is the frequency again of what? Because now you show one graph, right?
Okay. We'll go to the distribution first.
Yep.
Okay, so this is the increment of the ablation, the post-ablation minus pre-ablation. So you have a heart and you compute the maximum frequency, let's say 8 Hz. And then you ablate with one type of therapy and you compute again the maximum frequency and you get a 7. So this means this is a -1. So you get one value here, -1. But if you try another therapy and you get 10 Hz, you get a 2. So you get +2. So this is the difference between the post map and the pre-map.
So this is the frequency given one ECG.
Yes. Yes. 1 gram. So many cases the ablation didn't do anything. That's why I get a 0. And some of the cases it went well because the frequency went down. And some of them they went wrong because they went up.
Okay, so one more question about this. You said that the important frequencies, I think on the previous slide, were like 3 to 12 hertz.
Yeah.
Can you say a bit more about why that is?
Because that's where when we have a patient with arrhythmia, normally the frequencies in the atria are between 3 and 12 hertz. That's not a difference. That's a absolute.
Yeah.
So if you have a healthy patient, you will have 1 hertz, right? 1 second, 1 beat per second. But when you have more beats, you get the higher frequencies.
Yes. I
That's-
was a bit confused because 1 bit per second is 50 hertz. Right?
And so, you compute. Sorry, I got confused. You compute the maximum frequency. Sorry.
Okay. Okay, thank you.
Thank you very much for your presentation. I wanted to ask, first of all, a clarifying question. You created your GNN, okay, in which the nodes are the electrodes, and the connect between the nodes, what are those?
I chose to make the closest neighbors because the signal from electrodes that are flow, they look the same, more or less. So they have a high correlation. And also I try not to connect electrodes that are in the back and the front. Like this one in the back is not connected to the one in the front. So yeah, just the neighbors electrodes.
Okay, so they are something like the relative position
Yes.
of the electrode.
Yes.
Okay. Second question was, you said that you had a scaling of 1 to 4 concerning the importance of each electrode.
Yeah.
Is that does that come from medicine or does it come from computer science?
From computer science for me.
Okay, so it's not
a specialist's knowledge.
No,
Okay. Is there any knowledge from medicine that could help you in this part? Do you know?
I don't think so.
Okay. Okay.
Because, well, first of all, they don't work with artificial intelligence, and they don't work either with the vest, with the electrodes. They go with the catheter.
Okay. Then again, I'm not related to the.
No,
uh,
I
to-
don't think
to-
they use this.
Okay, but then again, I would say that the doctor may have some kind of notion of whether some signals may represent some part that I don't know. I would just suggest looking for some knowledge from the expert in that
Okay.
part. Okay, and the last one was, did you try experimenting with more traditional models?
No.
Okay,
My group works with traditional models, but in other problems. And I am the first one in my group that works with graph neural networks. Yeah, I think that the best is good for the graphs because they are non-linear, like the position. My colleagues work with images, so they have the problem in the side of the torso with an image because the back and the front is one close to the other. So we don't know how it works in that places. So I think with the graph I can sort that. And also they have to transfer the ECG signal to an image, and I just go directly.
okay. I was thinking, but then again, I told you I'm not related to the field, but I could see this as a problem with simple tabular data
Mhm.
and then XGBoost regressor. Right? So I don't know. Okay. Okay. Thank you.
Okay.
Thank you very much. I was wondering about the data set. So you use the same data set for training and evaluating with cross validation or something?
No, I divided the data set. I divide by HCRs. Like this data set is made of 28 HCRs. So I use 26 for training, 2 for validation, and 2 for test. So each HCR has like 300 simulations.
So you mentioned an issue, let's say, about too many zeros.
Mhm.
And I was wondering, since the data set is simulated, is the simulation random, or is it somehow designed to represent how ablation would be done in a patient?
Yeah, the ablation strategies are established. These are anatomical ablations. So this is what is done in clinics. They isolate certain parts. Like for example, this is the pulmonary veins with the box. So these are not random. What is random is the AF simulation.
This strange, let's say, situation with the distribution is realistic, is how it is.
Yes. Yes.
Okay.
Mhm.
So it is a real problem, it's not an artificial one.
Yes.
See.
If anybody has any questions, stop me. Thank you, Maria. Every time I hear, it's the third time I hear the presentation, and but you add information. For me, I learned something more. And I have many questions. So, when you put this vest, do you place the electrodes in specific locations? Do you have to be very careful where you place the electrodes, or is it very?
I don't place the electrode, but I think they have to be in certain places,
But-
more or less.
So it's like the
The 12 ECG, yes, yes. Yeah, we have the problem that some patients are bigger than others, so it is not exactly in the same place. But yes, more or less we know the
Does
position.
this affect the simulation as well? So do you have different
Yes,
types
yes.
of bodies?
Yes, I have different types of torsos. Yes, these instances come from real patients. So I have like 5 female and 5 male. Some are fat, some are thinner. I have differences. But the torso is not the problem. If you have a thicker torso, the only thing that changes is the amplitude of the signal. What really changes the signal, the ECG signal, is the shape of the atrial. If it's smooth or it's bigger or small. That's why I divide my data set in the atrials, not torsos.
So it's different types of it.
Yes.
Regarding the first problem that you mentioned,
The location.
where you hear a scar.
Yes, the location of the frame.
You mentioned a number regarding the accuracy, but I didn't get it.
34. 84, sorry. 84 accuracy.
So you can find, what do you mean by finding the location? Do you mean, have you separated the heart in specific?
Yes, I divided the heart in 6 parts. And these parts are usually where we find the fibrosis in real patients.
So the system says if there is a problem in a specific part, or if there isn't, it doesn't tell you how big it is.
Here I only present the location, but I also did the density. So I did 2 GNLs, one for the location, it says the part from 1 to 6, and another I did another one for the density. I said small density, medium, or high. So another classification.
And we get similar good result.
I got an 87 for that one, but it's very imbalanced. So many cases were below a certain threshold. So many cases with low density. But the location was balanced.
7 was forever.
Accuracy. 87 of accuracy. Yes, it's another classification.
Again, if you have a question, interact.
I'm sorry. I was just thinking now that George asked about that if you can tell with relatively good accuracy where you have fibrosis or what scars are called, then you probably can say a lot about which type of ablation will do anything, right? Because you have some type of ablation procedure which is focused on a particular place. So if you see that another place has fibrosis, then that is very unlikely to be effective, right?
It's not the same problem because with fibrosis, I use sinus rhythm, which is like a normal beat because AF patients are not all the time with AF. They sometimes have sinus rhythm. So I work with sinus signals, which are less complex. But with this type of problem, I have to use AF simulations, AF signals. So the ribbon, if you remember. Yeah, I saw before the propagation. 1 second. So here, this is the sinus rhythm. Play goes forward in normal way, and then I put the scar and I reproduce again the sinus rhythm. But with the other simulations, I have the chaotic signals. So the signal is more difficult to process. That's why I think I get the errors.
Okay. Yeah. No, I'm asking myself many questions. Anyway, the other random thing I wanted to say is that I think there's a lot of work, I don't know particularly about ECG, but I'm sure there is, about using actually frequency representations as the input instead of the signal. I don't know exactly how you do it, but I'm sure that there's things where instead you can use some kind of convolutional networks or other vision models where you use the Fourier transform of the signal, or something that has both the frequency and the time, which is like the short time Fourier transform and other things. And many times these are a lot more useful when doing things with signals and biomedicine, because also then you can do a lot of explainability with seeing where on the frequency spectrum it's more important, and sometimes it's easier. So just an idea that
Yeah. Mhm.
using the raw signal sometimes is harder than using the frequency representation as the input.
For this one, because it's a simpler signal, I use the signal directly. But for the others, when we have AF, I use the periodogram of Wells.
Okay.
So yeah, like a transform.
Okay. Again, if you have questions, interrupt. Um, and another question that I had was about the explainability that you're doing with the. I agree first of all that I think I've already mentioned that the attentions are not necessarily very good predictors for explainability, but let's assume that they are for the moment. Have you tried to identify if different electrons, if different nodes of the network are somehow correlated with different classes?
What do you mean by that?
You had a multi-class problem, no?
Yes.
And maybe some part of the network are important for some class and some other part for another.
Yes, I saw this. So for this example, this is for the pulmonary vein class. This is just one class. For another class, we have maybe the electrodes here. I just saw one example to make it easier. But yes, I saw, and I said it before, when I had a big scar, so most of the atria was with damage, these colors was like everywhere in the torso. So when I remove electrodes, the network could say that where the problem is, because the importance is distributed when we have a lot of damaged tissue. And that's why, because we see the signal from every point. When the area is big in the heart, you can see it everywhere, more or less. But when the area is small, the GNN specifically focuses on parts. And what I think is that they focus when they have direct line of sight. So this here, I don't know if you see the red, this is where the damage is placed in this case. So it's in the vein. So we have direct line of sight here. And here, for example, it's a light pink because we don't have direct line of sight, because we have the left atria in the middle. So that's a superior vena cava where it's the damage, and we don't see it here. But here we have also direct line of sight.
Interesting. I wonder how you could use that to change the structure of the graph. If you could use the line of sight to change the structure of the graph.
Yeah.
Maybe just connecting the neighbors basically may not be the best thing to do. If the line of sight is so important. But I don't have a better proposal, so I don't know.
I tried another distribution, not the neighbors, computing the correlation of the signal, but it didn't work well. So that's why I came back to the distribution.
Okay, interesting. And you have one single network trained for all classes.
One for location and one for density.
Yes, but you don't have a separate one for each class.
No. One for all the classes.
And I guess it's a GAT which is shallow. It's not very deep. It doesn't have many.
No, it had like 8 layers.
Does it work better with
Yes. Yes, it works better.
Interesting. Dimitri, what do you have to say about it? Why does the gut work better with many layers? Well, many 8 layers.
Sorry, what is the gap?
The gut
8.
Yeah.
it works better with 8 layers than fewer.
Oh, we have discussed with Maria that maybe the suboptimal results are due to the depth of the model, and currently she's using a GAT with 4 layers, or 5,
In this problem, I had 8 layers.
8 layers.
With
Yeah,
4 layers, it worked worse.
yeah, and she's currently working with 4 layers, and it's on the road to make an experiment with 2 or 3 layers to reduce the number.
My question is what, not in the current results, but the previous results you had, why would an eight-layer GAT work better than a 4-layer GAT?
I think in that type of problem, it's not an 8-layer GAT should not work so well, in my opinion.
Experimentally, she said that the 8-layer GAT works better than the 4-layer.
Yeah, maybe it's due to suboptimal parameter tuning of the other models, because, or it's a special case of that type of problem, and 8 hops away are needed to access distant information. But with such a densely connected network, I would suppose that 8 hops are too
It's not
far.
very densely connected because it's only locally connected. So if you, she said about line of sight, right? So if you're trying if you have activation in the node that is like 5 hops away from the heart, because the node is in the line of sight, so because it's on the same nerve, or whatever, I don't know exactly, then you have to account for this 5-step distance.
Yeah, probably, but I don't know. Generally, 8 hops are kind of deep for such networks.
It's interesting to see. What I mean is that it's interesting now that you're working together to go one step back and see why it happened in the previous experiment that Maria was doing. Why was the depth important?
Maybe it's a case similar to the star graphs. I don't know.
If it is, it's very interesting because it's a real world problem instead of the star problem, right? That's why I'm asking.
Yeah, probably.
Well, one thing that I did per graph, per simulation, I eliminated like 10 electrodes on purpose. So I didn't have like the same graph every time. And I eliminate 10 electrodes randomly. Maybe that's why the network needs to have more hops. I don't know.
So why did you do that?
So per patient, per graph, I choose 10 between 10 and 20 electrodes and remove them.
Is that because it doesn't happens because sometimes it
I-
don't work well? Or?
Yes, I did that because sometimes in clinic you have noise, some of the signals or they lose the electrodes. It's like 128 is too many. You always get the bad result.
I don't think that should explain the reason why you need deep network. It's interesting. The reason why I'm asking Dimitris is that for a very long time we have argued that deep networks are interesting, but we never found a real problem where they are needed. So it's interesting that you have one such problem. That's why I'm asking. Now, coming to the problem that you have now, so you are still using the GAT, right?
Yeah.
And if I understand correctly, the way you try to address this problem is through graph classification problem again.
The location or what? Or
No, the
one
one,
now?
the one
No, regression.
graph regression. And the value that you're trying to find
Is the difference pre-ablation, post-ablation. So how
okay.
many hertz in frequency we
So
change?
the type of ablation is actually an input
Mm,
to the system.
more or less per patient, I give 12 numbers, and each one represents one type of ablation. I have 12 ablations. So the first one corresponds to one ablation, the second number corresponds to another ablation. So per patient, I estimate 12 values,
Yeah.
and this represents each ablation.
And you have different input for each pair. For each patient, you have 12 different simulations.
Yes.
Okay. And you're trying to, and you have a simulation for this patient before and after the ablation.
Yes. Mhm.
And how do you take that as input now? How do you take, what sort of input do you give?
My
it?
input is the signal, the one, well, the spectrum,
Which one? The ablation or the
the pre-ablation, before. I don't know anything because you cannot perform different ablation to a patient. You have to choose one. So in real life, you only have the pre-ablation signals.
Okay. So and you're trying to predict with 12 different, so you're trying to predict with this pre-ablation situation,
Mhm.
what would be the difference
Hmm.
for each of the 12
Yeah.
classes? Okay. And you're not using 12 different networks. for that.
No, I'm using the first, just one.
Okay. It might be worth trying 12 different ones because
Mhm.
if you have one different network for each ablation type, it's still realistically useful, right?
Yes, yes, you have to train 12 times. But
Yeah, you have pure data.
I did one experiment with that, but I got the same results. Like a lot of in zero and few, but I only did once. So I have to work on that.
Okay. And you have not still tried any temporal
No.
method? No.
Not.
Hmm. Interesting. Okay.
So I've seen some architectures in the context of anomaly detection where they combine different architectures, each trying to detect a particular aspect of the problem, for example, temporal or spatial resolution or information. From there and combining them in order to perform a classification after. So it would be interesting if, for example, we try to combine the 12 different networks that we were just talking about. If maybe there are some correlations there that if help one another to make a better judgment of that. Or maybe possibly in future work if you try to add temporal information to the network might also be allowed for
Okay. Yeah, to divide the problem.
Correct.
Like divide the training. Mhm.
So in the slide where you showed your results for the one you're doing now, you had a line. Why is that line different from the distribution of the next slide?
So,
Yeah.
this one, you know?
3 slides back. The one before? Yeah.
This is the 1 second. I think I stopped sharing the screen. Really? No. We wait. Can you do it? Wait, just for people to see. Okay.
Yeah. Can you
So-
say what the axes are?
This is the real values in
Of what? Of the frequency change?
the ground truth. Yes, the frequency changes. And these are the estimated values. So the blue line will be the perfect. If we estimate the same as we predict, as the real value, sorry.
I was just wondering because the red points kind of looked like the distribution of the next slide,
Yes, yes.
which
Okay.
is,
The problem is in the database. Yes.
as in, I don't know, from a machine learning perspective, it seems like you're learning the data.
Yes.
Okay.
Yes, that's the problem.
How long are you take? How long are your signals?
10 seconds. 10 seconds.
Okay, because you could also experiment with how long your signals are.
Like only using one.
Only using more or less, because
Mhm.
some things, especially when they're slower within whatever activity you're measuring, may require a larger signal, a longer signal to detect.
Okay. But I don't use the signal, I use the transform. But I can do the transform of a short signal.
Yeah, you could do the transform of a longer signal or of a
Yes.
shorter signal.
Mhm. Okay. I can try.
Why do we have this picture? Why is everything so close to zero?
Because many ablations didn't work.
So you have a very high imbalance
Yes.
in the data, in the training data. no?
Yes.
But you could try to change this in the
Mhm.
training data. In the test data, I would not recommend it. You can leave it as it is. But in the training data, you can change that. You can have fewer failures.
Yeah, to eliminate the cases with zero, right?
Have more balanced training data set.
Then I will have a few data sets, few samples.
Can you give us the numbers because I don't.
It's 8,500. So if I use only this part, it will be 1,000.
No, I'm not saying you should use only that one. But you said you have 8,500 simulations in total,
Mhm. Yes.
which means that you have 12 times this in terms of,
I have.
12
Yes.
different classes of it. The way you see it now. I would actually split that into different training data, so you would have 12 times that. But anyway, it's the same. And from those 8,500, these are the ones that you are looking for.
Yes, these are
The
all of
8,500.
the whole data.
And I saw, sorry, I'm talking out loud, but I saw that you have another frequency which is probably per ablation type, right?
Yes, I have a
Can you see?
I only have here 8 ablations
Because
But-
the other ones are not.
because the other ones are, some of them are wrong. So I'm waiting for my colleagues to complete
on the
them.
data.
Yeah, these are anatomical, so they are fixed. They are fixed to anatomic regions, but the others are based on some other parameters from the signal. That's why they have problems.
All of those patients have arrhythmia, right? So
Yes.
there are no
Yes.
healthy. there
No,
are
no,
not
no.
healthy.
All
Mm.
have everything.
Okay, so it seems that all of the, or almost all of the
Yes, many
cases
are.
that have, and but this could also mean that per patient you have, no. How does it work?
Yeah, I wanted to ask the same thing, which is, have you checked per patient how many ablations are successful? Because if you do 12 for each patient and maybe one is successful,
That's
then
what
this is
happens.
completely normal.
Yeah, I didn't check all of them, but more or less per patient you have 0 is the most common, like 0 ablation work, but maybe 1 or 2, 3 maximum. I think.
You could try what George is saying, in the sense that you use, maybe if it's 0 out of 12, you use some of them, or if it's 1 out of 12 that is successful, you use 1 successful and 1 unsuccessful for the training.
Okay, yes.
I would actually start very simple. I would choose one ablation study, one ablation type,
Yeah.
and try to predict only that, and ignore the others, so that you see whether you can predict only one.
I tried that, only played one, and I got the same results, more or less. What we want to do now is try one, for example, but only I do 50-50 database. Or just training with the cases that work well. So to see if you can. If
Okay,
they can-
so let's assume that you have one. So
Okay.
you still have like 8,500 instances.
Yes.
And you have more, I would assume that if you choose one that is the most successful one,
Mhm.
the one that has the most successes.
Yeah.
You have maybe 800 positive and
Yeah, the rest
8,000 or almost 8,000 negative.
yes, more or less.
So if you subsample the negative class and you say you go for from 8,000, you go to 1,000.
Mhm.
So you have 800 positive and 1,000 negative.
Yes.
I think that's fine.
I would
It-
say.
It's not,
Yeah.
it's not, you don't need a lot of data because the data that you need are from the negative class. You don't need any from the positive.
Mhm.
In the training section.
In training, yes.
I would do that. I would start with one, the most successful one, ablation type, and I would do subsampling.
Okay. Yes, we were planning to do that.
I will stop.
Okay, thank you, everyone. If there's no other question, even from people online, let's thank Maria again and also mention that she will be here the next 2.5 months. So feel free to. She's sitting to 1.8.4, which is where Agathi is sitting. I think that's here. So yeah, you can reach it there. Thank you very much, Maria.
Thanks to you.